Thank you very much. If I could have my slides, I see them here. I don't see them on the screen. Okay, great. Thank you very much, and thank you for extending the invitation. I've been tasked to talk about how to become a better TAVR operator in 2022, and it's be presumptuous of me to address such an audience and assume I know better, but I'll give you the data and the way I at least see it. The way I look at it is we first of all need to recognize where we currently stand in the Gulf region. And identify areas of improvement if we want to answer this question. Then the other thing we need to keep in mind is understand the changing patient population that we are now treating, primarily lower risk patients with longer life expectancies. I think these are the two key things we need to keep in mind when trying to answer this question. We're lucky that we now, I think for one of the first times, have actual regional data that tells us how we're doing and where we are. This was published in CRM this year. It was also simultaneously presented at the CRT meeting in Washington, D.C. It's a TAVR registry that involved 4 Gulf countries and 8 TAVR centers. It was a retrospective cohort study for patients undergoing TAVR at 8 centers in the Gulf. The primary outcome was a composite of death and rehospitalization at 1 year. Secondary outcomes include individual components of the composite, as well as stroke and MI. 901 patients were screened. 817 met the inclusion criteria. These patients were performed between January 2017 and the end of December 2019, allowing us for the follow-up data we wanted. 22 patients were excluded due to loss of follow-up at 1 year, and therefore close to 800 patients, 795 patients were included in the primary and secondary outcome analysis. And this is a breakdown of the baseline characteristics, really nothing surprising, about almost an even split between men and women, the mean age of around 75 years old, concomitant coronary artery disease in about half of the patients, prior PCI CABG in about 30%, peripheral arterial disease in just under 10% of patients, and the vast majority had normal renal function, but a significant proportion, about 20%, had stage 3 or greater renal dysfunction. Again, primarily a tricuspid valve population, 95% were tricuspid valves. The mean gradient 46, aortic stenosis mean area 0.71. Primarily patients had predominantly normal LV function, although again a significant proportion, around 24%, had significant LV dysfunction. The mean STS mortality for our patient population in the Gulf for these close to 800 patients was 4.9, with just about half of them being considered low risk with an STS score less than 4%. Let's look at our results. Our acute procedural success in the cath lab, we're doing well. We're doing very well. 99% success rate. Our mean gradient is around 10 millimeters of mercury. Moderate or severe paravalvular leaks in only 4% of patients. A primary pacemaker implantation rate during hospitalization of around 10%, 9.7%. The really bad complications, coronary obstruction, rupture embolization, all less than 1%. Where we do have a problem, I think this is one area we need to concentrate as we move forward and become better TAVR operators, is our incidence of major and life-threatening bleeding, around 19%. And I think in 2022, that is too high. Post-TAVR stroke, 1%, in-hospital death of around 2%, and our median hospital stay of around 4 days. This was the primary outcome. Remember, the outcome was death or rehospitalization at 1 year, 12.8% of patients. If we look at the two composite components, death in 5% of patients and rehospitalization in around 10% of patients. Let's take a deeper look at this and see where we might be able to improve. If we look at cardiovascular causes for rehospitalization, 72% of them were due to either implantation of a permanent pacemaker following hospital discharge in day 30, or readmission for decompensated heart failure. And I think these, again, two areas which we can focus on in improving as we move forward. Chronic kidney disease in our data set, at least, was significantly associated with the primary endpoint. With those with stage 4 or 5 kidney disease tended to do worse over 1 year follow-up. I guess this is not unexpected. A low ejection fraction was also associated with the primary endpoint. However, it did not reach statistical significance. Well, again, we have 800 patients, which is a good number, but maybe if we had more patients, this would have reached statistical significance. Moderate to severe paravalvular leaks was also associated with the primary endpoint. However, again, it did not reach statistical significance, and this could be because of the low rate of events and the relatively modest patient population size. The conclusions we made at our presentation in Washington was that the Gulf TAVR registry is the first of its kind in the region. It profiles an elderly population with a high procedural success rate and a low rate of acute complications. 1 year outcomes were primarily driven by repeat hospitalization for heart failure and pacemaker implantation. The registry indicated the need to optimize heart failure management and improve algorithms for the detection of conduction abnormalities. So, to answer your question, how can we become TAVR operators as we move forward? Based on local data, we need to develop strategies to reduce bleeding and vascular complications. 19% is high. Identify post-TAVR patients at risk for developing delayed heart block, so that these patients can be treated more appropriately before they present to the ER in bad shape. Optimize guideline-directed medical therapy for heart failure in post-TAVR patients, especially those we know are at high risk for developing acute decompensated heart failure on follow-up, those with LV dysfunctions and those with chronic kidney disease. So how do we go about reducing vascular access site complications? Well, as in the previous talk, multi-slice CT and a careful analysis of the CT data in selecting your primary access site is of paramount importance, and I cannot stress this enough. Obviously, right or left femoral makes no difference. You're going to decide on which femoral to use based on the CT data, which one is more favorable, larger in size, less calcification, less tortuosity, so on and so forth. This is an interesting paper, though. Once we take the patient to the cath lab and we've decided we're going to go with, let's say, a right femoral approach, how do we access the femoral artery? This is a study from a single center in Canada which compared two-dimensional ultrasound-guided femoral access to traditional angiographic-guided access, and actually found that whether you're looking at access-related major vascular complications or bleeding complications, these were all significantly reduced by adopting an ultrasound-guided approach to femoral access for the TAVR procedure. Now, the limitations. It's a single-center retrospective analysis, only 387 patients. It could not distinguish between vascular complications and bleeding related to the large bore access or related to the secondary access sites. Because in this population, both the primary access point and the secondary access points with a femoral artery, in this retrospective analysis, they could not differentiate between complications related to the primary or to the secondary access site. This is a larger study from the UK, which looked at close to 1,600 patients. Again, it's a retrospective study, and again compared 2D ultrasound-guided femoral access to fluoroscopy and contralateral angiography-guided femoral access, which most of us do. And this time they found there was no significant difference, so it may still be up in the air. Limitations, though. Again, this was a retrospective study. Again, it could not distinguish between vascular complications and bleeding related to the large bore access versus those related to the secondary access site, because again, both access sites were femoral. And again, it compared routine, all-comer use of fluoroscopy and angiography-guided access to 2D ultrasound-guided access in all patients. Therefore, it cannot exclude benefits of ultrasound-guided access in higher-risk patients, especially those who are severely obese, those with heavy calcification, or small-caliber arteries or large artery-to-sheath ratios. Okay, secondary access site. Can we do anything here? This is an interesting study that compared a secondary access site femoral versus a secondary access site radial. Most of us, at least I do, femoral on both sides. So primary and secondary access are femoral. And on the right-hand side, you can see the transfemoral group. Down here in red, These are the major vascular complications related to the secondary access site, the small femoral artery you don't think about. About a quarter of all vascular complications are related to the secondary femoral access site. And by adopting a radial artery as the access site, major vascular complications were completely eliminated, and even minor vascular complications related to the secondary access site were significantly reduced. So there is something to be said to maybe considering the use of the radial artery as a secondary vascular access site for your pigtail. What other measures can we do to impact our bleeding and vascular access site complication rate? This is a study that looked at routine heparin reversal at the end of the procedure compared to no heparin reversal. And suffice it to say, they looked at both safety and safety endpoints, bleeding and thrombosis. So the primary endpoint was a composite major bleeding, stroke, life-threatening bleeding, and MI, and found that routine use of protamine to reverse heparin was beneficial and reduced complications. So to reduce access site complications, careful pre-procedural selection, potentially the use of the radial artery for secondary access, 2D ultrasound-guided access for the primary femoral site, especially in high-risk patients, and heparin reversal at the end of the procedure. How about prevention and detection of conduction system disturbances? Well, this is already the CT part has been mentioned by the previous speaker. Things such as heavy LVOT calcification, short perimembranous septum are predictors of conduction abnormalities. Pre-existing right bundle bifascicular blocks on the baseline EKG are also very strong predictors of conduction abnormalities post-TAVR. Post-procedural EKGs that show any form of heart block or prolongation of the PR interval can also indicate patients at risk for delayed heart block after hospital discharge. And procedural factors. Depth of implantation is important. Most of us now have adopted a cusp overlay view to try and minimize the depth of implantation, and that goes some way into helping reduce the rate of pacemaker implantation. Selection of the valve. We know some valves do have a higher pacemaker implantation rate versus other valves, and maybe you should use a valve with a lower implantation rate if the patient has multiple indicators that says that he's at risk for heart blocks, such as pre-existing conduction abnormalities or a short perimembranous septum. This was a study that looked at patients who were discharged 48 hours with no indication for a pacemaker implantation. They routinely had a 30-day monitor. They found about 10% of these patients developed heart block requiring pacemaker implantations after hospital discharge, mean occurring 6 days post-procedure with a range of between 3 and 24 days, very similar to what we saw in the Gulf TAVR registry. So they were able to be picked up on monitoring. And in this study, the multivariate analysis predictors for any heart block post-TAVR were right bundle, the use of a self-expanding valve, and hypertension. On multivariate analysis predictors for a delayed heart block after hospital discharge after 48 hours was only right bundle branch block. Importantly, though, delayed heart block occurred in 8% of patients with no identifiable conduction abnormalities at 48 hours. In fact, the ACC has published a document that gives us some guidance as to how to deal with these patients. And those patients who develop any degree of heart block during or after the procedure, whether this is a first or second degree AV block or a new bundle branch block or progression of an underlying conduction abnormality they had that's gotten worse, probably should be monitored for at least 48 hours to demonstrate that it's not progressing any further, and should probably be, or at least consideration given to discharging them on the long term, at least a 14-day or 30-day monitor to pick up conduction abnormalities that are getting worse before they essentially present to your ER with a complete heart block. The last thing that we learned from our data was that we have a not insignificant readmission rate for heart failure. And I think we need to make an effort in following these patients close. It's not enough to just implant the valve and send them home and think we've done a job. I mean, these patients, especially those with risk factors, those with bad ventricles or moderately dysfunctional ventricles, those with chronic kidney disease, we need to start and initiate guideline-directed medical therapy while they're still in hospital and make sure they have appropriate follow-up in specialized clinics so that we avoid this unnecessary rehospitalization rate. What else should we be doing going forward beyond 2022? Well, as we're treating younger patients, I think we need to start thinking of a lifetime strategy for the patient, not just what are we going to implant today. And this will involve deciding on whether you're going to go down the TAVR route first, followed by TAVR, or the sequence of events, especially if the patient's very young. I just have 2 more slides.
Can we have more extra minutes?
TAVR, 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 TAVR. So these are all things that we need to be thinking about, especially when you're faced with a younger patient. And if you're going to start with the surgical valve in the young patient and implant TAVR later, the surgeon, you need to talk to your surgeon. He needs to implant a valve that is going to be subsequently TAVR friendly. Something that is crackable, try to enlarge the root if possible, something in which the valve leaflets are mounted on the inside rather than the outside. And if you're going down the TAVR route first, again, selecting an initial TAVR valve that makes a subsequent TAVR easier. So maybe an annular valve first, followed by a supraannular valve later, reducing the risk of sinus sequestration or coronary obstruction. So all these are things we need to think about, not just what do we treat the patient with now, but put a lifetime plan for him based on his expected life expectancy. Different if you're talking about a 50-year-old when you're talking about a 70-year-old versus a 40-year-old or a 30-year-old. Again, recognizing the importance of coronary access, especially as we move into younger patients. This may have a bearing on the valve you select initially. Perfecting commissural alignment techniques, which are valve-specific. They're not available for all valves, but certain valves. There are ways in which you can at least try to get commissural alignment. Develop expertise in novel coronary protection procedures such as basilica. We have very limited experience in the Gulf region with these type of procedures. And possibly starting to think about adopting embolic protection, which I know is not used very frequently in the Gulf, but as we use to younger patients with longer life expectancy, potentially more bicuspid valves, more valve-in-valve procedures, potentially more basilica procedures. All these type of procedures have a much higher rate of stroke, in which you may want to then start considering embolic protection. Thank you very much for your attention.